I want to take a few minutes to share with you some principles that I hope will be helpful to you. We've had some amazing teachers already this morning, and a lot of you may find it a challenge really to identify. You know, I'm a guy. I'm in private practice. I just have a clinical sort of approach. I'm not really all that interested, or really don't maybe feel so capable when you start thinking about trying to share these things. And it's a frustration if you're like that. You know, you kind of have this sense that, wow, that would be great if I could do that, but I just don't have the the stuff, to try to put that together. And so what I want to share with you this morning are some things that maybe could help you to sharpen your skills. Maybe could challenge you to maybe think again about whether or not it may be something that you could be involved in. We all would like to feel capable, when when we're involved in the different things. We love to do good surgery. It's just so rewarding. And teaching is no different. You'd like to feel like you're really a good teacher if you're going to be involved in that, right? So what are the things that make that up? Those are the principles I want to talk with you about a bit this morning. Well, there have been so many changes, new technologies that we've talked about, technologies in how we deliver care and how we do compliance, auditing, technologies and access to information, the information age and the technology age that we live in. But in the world of training, there's really been relatively little change. So far, what we've been talking about is a age-old model. The model of Jesus, even as Pedro just said. It's mentoring. It's talking to another person. It's engaging with them as an individual. It's the relationship that bonds you together as you're sharing and communicating those things. So very little change. And technology really hasn't been a great, hasn't really provided a lot more to that. So we still use the, kind of a traditional 100-year-old model, sort of focused on apprenticeship. But there are some things that are happening in our world that are increasing the pressures to address cost and to reduce patient risk, of course. So as I've discussed these principles with the Western surgeons that are involved in Western training centers situations, that's their interest. What can I do to be a better instructor to reduce risk to patients and reduce the pressure that I'm feeling to produce good trainees? There is some new technology. I'll share a little bit of that with you later today. Some things that are changing. There are some new things that are coming along. But for the most part, it's just now starting to make an impact. So just a bit, some of this comes from my background in training over the past 30 years and 10 years really in international training. And M6 training, really manual small incision cataract surgery training really kind of changed my strategy. One, it was international. It was involved with people that didn't necessarily have the same background I did. Two, is that the technique itself was not as driven by knobs and buttons and settings as it was by skills and art. And for that, it required a different level of communication that in some ways I really enjoyed. And for that reason, it forced me to adopt some changes in how I was doing things. So I wanted to present some of the things that I've learned. First of all, and maybe most important, is that it's no accident that you become a good trainer. It's no accident that the people that you've heard this morning already are noted as great instructors. They're good teachers. That wasn't an accident. They didn't just sort of stumble into becoming that. They learned some skills that helped them to do that. And in fact, they learned how to do some carefully orchestrated, I would suggest, they've learned to do some carefully orchestrated interactions that they use to be the instructors that we know them as. I've broken it down into three components three essential components, I believe. The first is, and this is not surgical skills, this is instructional skills, skills that you actually need to be an instructor. which is different than surgical skills, but nonetheless it's a skill. It's something that you learn. Secondly, it's knowledge. And again, this is not clinical knowledge or anatomical knowledge. This is what knowledge you need as an instructor to be effective. And third is attitude. And again, this is not the kind of attitude, how do you treat patients right? How do you treat them nicely? I loved Dr. Gomez, his presentation. So he was so focused on those attitudes, right? It's creating the environment that someone learns. How do you adult education is sort of this weird thing. It's not like children who are sitting there lined up and just need to hear what they need to know. These are adults who are processing and analyzing and have their own issues to deal with. And how do you create an environment where that happens? It has a lot to do with the attitude of the instructor. So let me talk about I'll talk about those three things. It's a complex task, but it is something that can be taught to those who have an aptitude for teaching. I firmly believe that's true. And I believe that it's something that we can encourage each other in to hone our skills. Just like we hone our skills in being surgeons, why would we not talk about being better instructors? Why does that not happen so often? I guess it's my thing, maybe, that I just think it's such an important role for us to play. And you've heard some of the impact that has. You've seen some of the lives that represent what that can mean. And we have the potential to do that if we could sharpen each other in these arenas too, I believe. M6 training, this just gives you my background. One trainer, hands-on delivering, 3 weeks or more of training is the category I'm talking about. So this is not the one-day wonder, that go in and someone watches me do surgery for 5-6 cases and then you say that's training. That's not what I'm talking about. I want to share with you sort of an experience that's more extended to that and what it looks like if you do at least 3 weeks or more of training. This is with 49 trainees in 18 countries. The trainees were a mixture of phacosurgeons, some who were extracapsular surgeons, and some who were different designations used in different countries. Sometimes they're called medical officers, sometimes they have different designations. They've got their medical diploma, but they haven't received any subspecialty training, and so there was 10 of those over these past years. The objectives were, first of all, to raise them to a level of competency. That is, that they were able to operate efficiently with a 5% or lower complication rate. Now, 5% is not great, I'll grant you that. We want to see 1% or less. Of course, is what, if you were in practice and your complication rate was 5%, you and your partners would be worried. That wouldn't be a great number. But 5% I think is reasonable for a novice surgeon or someone who's just finishing their practice, and you need to have some bar, right? If you don't have any bar, then anything's okay. So at least I set a bar. This is what I said in my hands. I want to shoot for 5% or less complication rate. And secondly, that there'd be a high level of confidence that they would be able to problem solve and contextualize the issues that they were faced with, and wouldn't always be saying, "What do I do now, Professor?" Right? That's the usual thing. If they look at you and say, what do I do now? They haven't achieved the level of confidence yet. As soon as they are working and they say, "I think this is what I should do," when I start hearing that, then I start thinking, okay, you're seeing what you need to see and you're processing the information that you need to achieve what you need to achieve. I've just emphasized again, mastery was not the goal in the training that I'm talking about here. 65% achieved both competence and confidence in that group. 22% became successful trainers, and I'm especially happy about that. To me, that's the cream of the crop there. Those were the people that didn't just get it for themselves, but they learned how to communicate it to others. 35% didn't get there, and my final things with them was to set up what do you do next? You really are not at a point where I would suggest you continue, because what happens when someone who's not really ready to do surgery goes into surgery? What happens to them? They start failing, and what happens when you start failing? You quit, or you hurt people. You don't want to do that. So, always set a path when you're training someone, even if you don't achieve what you wanted to achieve. At least set a path for your trainees. On average, 106 supervised cases per trainee is what I did, but the minimum was 35, And that happened to be one DSEC surgeon who was a cornea specialist. And I tell you, he had to be the best student I ever had at M6. I've done retina surgeons, cornea surgeons, extracapsular surgeons, phaco surgeons. And there was something about doing that, I suspect, that just made him particularly adept. And within 30 cases, it was like, okay, well, bye. You're ready to go. He was doing a great job. So these are some of the things that I've learned. Here's some of the skills that I think are really important. First of all, there's a skill involved in learning to be there and not somewhere else. Many of you may be even struggling with that a bit this morning as you're thinking about what's going on at the office. Text messages are coming, and the technology that we have kind of tends to push us into something else, somewhere else beside where we are. So it really takes a discipline of mind and heart to be present right there. The Socratic method, I'm sure you know what I mean by that. That's the art of asking questions in a way that stimulates thinking, that doesn't shut it down. It's not the question that says, what's wrong with you? That's a question. That's not the Socratic question. The question is, why do you think that happened? So what's wrong with you, and why do you think that happened? If you are the what's wrong with you question asker, that's not the skill you need. You may be very skillful at doing that, and what you are very skillful at doing then is intimidating people. And you wind up always being, the one who's in charge, because you've asked those questions that made people very clearly realize that you know much more than they know. On the other hand, if you've learned how to ask questions that empower them to explore, now you may not be quite so visible, you may not be quite so important, and they pretty quickly learn how to analyze and think. So a very important skill that's involved in facilitation. And I tell you, it's a skill. I was not as good at that some years ago as I am now. I really had to learn how to do that, and it takes some work. Secondly, being level-headed, is not, some of us may not be naturally level-headed. When someone makes a mistake, it's how do you respond to that? If someone says something, for lack of a better word, just stupid, they say something, you go, if the eye rolling, the whole thing is, that's what they see, then of course, what did you just do? You just communicated. There's, don't bother learning anything. You're an idiot. That's kind of what they walk away with. So that's not the skill. The skill you need is the skill that the self-discipline and the skill that comes from being able to stay aware of the situation, protect the patient, but still engage the trainee. And that takes some work. It takes some time to learn how to do that. Anticipating and participating while thinking out loud. The instructor, if you start talking and you forget what's happening, you drift off into your own world as you're thinking about something. That it takes skill to think and act at the same time. People who trained with me, the nurses who I worked with in some places, knew me pretty well, and they, I could catch the glance in their eye. They knew that something was coming because they could hear what I was talking about and watch what I was doing. And it was like there was this rhythm to thinking and acting at the same time. And that didn't come overnight. That took some time to develop that. It's a skill that you develop with time. Observing and really seeing what you need to see, not just what's wrong, but what's right. Understanding why. I love that Dr. Gimel has a physics background. Why is that useful? It's because he didn't just think about what he was doing, he thought about why it was working. He didn't just think about what is the next step. He thought about what is it that facilitates the success at the end. How does this all string together into a series of movements, tasks, fluid dynamics, and so on that then results in this great result? How did that happen? He started to think about how it is. That's what your trainees need to understand also, and it's what you need to think about when you're watching them work, because that's how you know how to catch what they're doing and make the changes in their thinking so that they can make the changes in their hands. Being a transparent third hand. I've had many trainees that walk away from their first 10 cases thinking they already learned how to do the surgery. And it's because they didn't realize how much I was doing. Now, when I first started training, they knew exactly how much I was doing because I was letting them know how much I was doing, and that wasn't a very good way to do it, it turned out, because then they were just worried about not getting in the way. I needed to learn to not get in their way. That's the skill I'm talking about here. Huge difference in the way that you approach it. So helping without intruding. And when you're talking about a tiny little space that you're working in and crowded around a microscope, it takes some skill. Just like you had to learn how to position yourself at the microscope to do your normal surgery, you have to learn how to position yourself at the teaching scope, and which eye is it, and how is the patient positioned on the table, and where are they sitting, and where you're sitting, and where are your legs so that you don't interfere with their legs, and that whole way of approaching this that makes you not intrusive but still able to facilitate takes some skill to learn all that. You have to know some things. There's some knowledge that you need also. Understanding cause and effect. I mentioned that a minute ago, as I mentioned with Dr. Gimbel, knowing what he did but why it worked. Knowing what I was teaching at a cause and effect level made me a much better instructor, and it took some time to think through the issues. Understanding the training patterns, the typical peaks and valleys in learning. If you do enough of it, it becomes obvious that there's a pattern to learning. Many of us have not had the opportunity to see that because we haven't done that much training, but I can assure you that there is a clear pattern that you go through. There's the initial rush, there's the imminent failure after, the first 25 cases, because now you know a little too much, but not quite enough. And now you're starting to analyze, but you haven't quite got it into your hands. And so if you're not there as an instructor, if you're thinking, okay, they're on their way, and now you've disappeared, they're at their most vulnerable point. If you didn't realize that, you need to be there at that point where now they're transitioning from just learning what to do to how to use good judgment. If you're not there for them during that time, you're going to fail them. So you need to have that knowledge. You need to have that picture in your head. You need to understand what are the sources of stress for your trainees, for the people that you're training. If you don't understand that, they're going to go through, they're going to have things distracting them from, you're spending an enormous amount of energy and time investing in these people, and you're letting them be distracted by all these problems. Why would we do that? Well, I did too. It's because I hadn't thought about, if I'm investing in that person, I want to make sure that all the things that would distract them from learning what they need to learn, I've dealt with. They don't know what to deal with. I do know what to deal with. I'm going to keep that from being a problem for them so they can focus on what they need to learn. Recognize that the surgical cues that predict problems. It's being able to look 3 steps ahead and know, if that happens now, this is going to be a problem 3 or 4 steps from now. So I need to address that with them. It may help you learn when to step in. It may not be immediately. It may be that you can let things play out a little bit with a little guidance, or it may be that you do need to step in. But knowing when that is a specialized knowledge for training, when doing skills training particularly. An attitude. These are things that shape us as believers, as Christians, as followers of Jesus, as Dr. Gomez said. These are the things that I think can define the difference between those who want to impart a spiritual component to the training that they're doing rather than just skills alone. So let me talk about a few of those. First of all, is communicating an attitude about the sanctity of life, I would call it. And by sanctity of life, created in the image of God, that our patient who is the poorest to the patient who is the most powerful, and everything in between, our staff, our nurses, everyone there is created in the image of God, and that gives them a special stamp of approval from God, regardless of their relationship to Him. They have been created in His image. Doesn't mean that they're followers of Jesus, obviously, which is our goal for them, but it does mean that they have a uniqueness that we need to recognize. And if you don't do that, if you don't communicate that, if in any way you miss something, if you treat nurses badly but patients well, if you treat patients well and nurses, whatever, it needs to be across the board that this comes across. And that attitude takes some time to cultivate in yourself, I found. It's a matter of personal growth also. Living by a code of service, that is a sense of sacrifice, that I'm willing to do whatever it takes for the best outcome for this patient. It's a simple concept, and I think we would all agree with that. But how do you work that out? How does that attitude show up? What are you willing to do that makes it clear that that's the attitude that you live by? And how do you, by living that way, how does that then get integrated into the lives of those that you're working with? Being an agent of delivery, not the doer of the surgery. It's hard to step back into the role of being an agent for training rather than the one who's actually doing the surgery. That's not an easy mental shift to make because that's what we're so used to. Fourthly, depending on wisdom, not power. And what I mean by that is it's the ability, and in fact, it's a little funny, I guess, because I obviously must do things a certain way over and over again because the residents will say, okay, you're going to stop and ask me, now let's think about that. Apparently is what I do a lot. And I thought, oh, well, great. He already knows what I'm going to say. I don't even need to do that anymore. So the reason I stop at certain points and say, let's think about that, is because I want a chance for wisdom to enter the picture rather than forcing some direction to take. If you don't stop for a minute, sometimes you don't get there, and the whole process stops. So wisdom is critical to the process and not just power. Trainees know when you want them to succeed. Dr. Gomez said it very well. That's what they want. They want the trainee to be better than the trainer. Jesus said, you will be greater than me, didn't he? Well, that's the attitude. That's exactly the attitude I'm talking about. And they know that somehow. I don't know exactly what you might say or do, but I can tell you they can see it. And being committed to the well-being of the patient, which we all are. So you combine these things and you get a real powerful tool. And over time, I've learned to use these things proactively, not just reactively. And it kind of keeps me from depending a little too much on technology, because that's sometimes what we do. Technology doesn't always meet the need. Sometimes we really do need to work with each other. So what do we have as, in conclusion, a few things about the older generation. What do we have to offer? Well, maybe a nice thing about being a little older, and maybe I am and maybe I'm not, but one of the nice things is maybe it's not completely enamored by technology. It's a nice thing. It's an incredible tools, but it's not the total solution. Not ready to abandon what has worked until it's clear what's really going to make a difference. And sometimes people that are training, that's what they want. They just give me the latest technology and everything will be great. The fact is that's not true. That doesn't really work all the time. There's really not that much new under the sun, and somehow people think there must always be something better and something new. You offer wisdom, knowing the right questions, knowing how to get the right balance into what's going on, because things can be stressful. So kind of keeping some humor in the situation is helpful, and it's hard to do that if you're pretty intense and under the gun. And always looking at the wonder of the situation. I love the idea that they look for miracles, Dr. Gomez said. I just love that idea. What does that do when you come into your operating room and you're not just wondering, will surgery go well? But the question you're asking the resident, I wonder if there will be a miracle today. Holy smokes, what difference does that make? I mean, goodness sakes, that's such a huge shift in the way that you even walk into the operating room if you're looking for something like that. And I'm telling you, in a training situation, that makes a huge difference. It doesn't mean that you're going to just do whatever and expect God to fix it. That's not what we're talking about here. What they understand is there's a bigger picture, and it's that bigger picture that those who are further along in the faith can offer to this situation. Each generation, of course, is going to need to figure this out, and as we think about transferring these things to the next generations, those distinctives are going to continue to be important, no question, and that's not the issue here. But Christian faith still is relevant, I assure you. Technology will never replace what the Christian faith has to offer, what our belief system has to offer, but it must be skillfully applied, and the basics of learning really don't change. We just need to be a little more aware of them, I would say. And I tell you, seeing them passed on is what makes it all worthwhile. So this is this fellow on the right is a fellow that I trained a few years ago, and he's now the head of the cataract division at the Nelson Mandela Academic Hospital. Because of the training that he got, it set him in a place where he could be a trainer for the next generation. And so he's in a little mission hospital here, working with this junior medical officer who's also learning to do surgery. That was I wasn't there, but it was just he sent it and he said, I know you'd want to know this. Such a blessing to see that. So what about you and your attitudes and your calling? I just encourage you to think about how you might participate in these things. We're going to take a little break for the next 20 minutes, I think, 20